Good afternoon. I always get that with my name because it's Lenora, Leonard. And it was an old English sister that turned around many moons ago when I started nursing, and she said to my mother, "Oh, Mrs. Leonard, what a tongue twister of a name you put on your daughter." I thought it was the funniest thing. But yeah, so I am the head of IPC in a hospital in Dublin. So this is our hospital here. So it's the Beacon Hospital. It's a private hospital with 181 beds. We have 8 very busy surgical wards that run 6.5 days a week. Believe it or not, we actually run half days on a Sunday. And so it's a busy role. So healthcare associated infections, and you know this already, you know, I'm teaching to the people that already know this, but is something that you've acquired or the patient has acquired as a result of a healthcare setting. So whether that's a nursing home or a GP practice or an acute hospital setting. And we participated in the European study, so we're back in May, so we're probably, what, 5 or 6 months ahead of you. We still don't have the final report, so it is a massive amount of work. But in the previous European PPS study, Ireland's HCAI prevalence was 6.1%, okay? And in the draft one at the moment, it's showing 7.5%, so that there is an increase in hospital-acquired or healthcare-associated infections. The private sector is looking at 4.1%, and in the Beacon we were 3.3%. And there can be a lot of debates over, you know, the public and the private sector, because obviously we have a lot more single rooms than in the public sector and private rooms. So the top 5 healthcare acquired infections are pneumonia, urinary tract infections, bloodstream infections, systemic infections, clinical sepsis, and surgical site, and particularly deep incisional. And you can see with the percentages that compared to 2017 and last year, everything is going up. Everything is going up. So whether that's a result of better surveillance that we're doing, or are our patients getting sicker, our patients are getting older, you know, we get a lot of chronic patients coming back into the organizations and that. But there are other infections that we have to think about, and that's the device-related infections. And there's been several talks today, particularly about urinary catheter infections. So your catheter-related bloodstream infection, catheter-associated urinary tract, and ventilated-associated pneumonia. So in the media, we all hear about these superbugs, okay? So they're costing a lot of money. So Dr. Brett mentioned 2.1 billion euro these additional infections can cost. There's superbugs is what the public know them of, the more increased morbidity, increased mortality, and even the CDC says that healthcare associated infections are on the increase, okay? So we practice these things all of the time, standard and transmission-based precautions. So we know our hand hygiene. There's been lots of talk about hand hygiene today and proper use of personal protective equipment. Early identification with infection, I think that's a key one, because the sooner you can identify your patient with the multi-drug resistant organism or the infectious diseases, the sooner you take measures to prevent the onward transmission to other patients. Good communication, IPC alerts, particularly between different departments, isolation, hygiene. Again, lots of talks. Professor Martin Corbican gave it, Kieran gave a talk earlier on, talking about the weekends, that there's less housekeeping at weekends, and yet the activity for patients is still the same as weekdays. Like, that's a very interesting point, you know. Education and training. The turnover of staff is extremely high. So education is a continuous thing that we have to keep doing and be present at ward level to teach people about good IPC practices. Audits and feedback, so that we have the information, we can measure it, we can monitor it, and we can, you know, take action, and surveillance and monitoring. So then we were wondering, what else can we do to try and reduce hospital-acquired or healthcare-associated infections? And we go through an accreditation process called JCI, Joint Commission International. So some of you might be familiar with that here. So we have 6 international patient safety goals, and IPSG, which is your international patient safety goal number 5, is all about reducing healthcare associated infections. And 5.1, which is a new standard, a new goal, is about care bundles, okay? So care bundles. So a care bundle is a set of evidence-based practices, generally 3 to 5, that when performed collectively and reliably have been proven to improve patient outcomes. So the key words in red are evidence-based practices, performed collectively and reliably, and improve the patient outcomes. And this came from the IHCAI back in 2001, actually, is when they start producing these. So what is a care bundle? It's evidence-based, it's 3 to 5 measures, but some people do have more in their care bundle, but it's all about keeping it simple, okay, so that all the staff perform these activities. Easy to understand, so there's no ambiguous, that people don't understand what's going on. Everyone is delivering the same care. All tasks are necessary, must all occur in a specific way, and standardized care. So that's what a care bundle is all about, is introducing these standardized evidence-based practice. So particularly, related to invasive devices. So we thought back in 2021, so when this came out, that we'll have to start looking at this. And we set up a group to look at care bundles in our acute setting. And so IPC chaired it, and then we had nursing staff, and we had the clinical facilitators and clinical educator came aboard, intensive care staff, and quality. And the first question we asked is, what care bundles do we have? And I remember asking that question to the group that came, and everybody was looking at each other. Do we have care bundles? What's a care bundle? And initially we thought we don't have any. We said we must have some. They're around the last, 20 years or so. So we couldn't get our head around the terminology, about it. Who is responsible for each care bundle? It's not going to be infection control, okay? So we're not, experts. I know we're experts in lots of things, but not everything. So, patients that are ventilated or urinary catheters, you have those experts, those clinical nurse specialists in those areas. So they have to be responsible for the care bundle. You can absolutely monitor what's going on and see, do we have good compliance? Which measures will be monitored, okay? And I'll give you some examples of how we found that very difficult to decide 3 to 5 measures in each of these care bundles. How will the data be recorded? Are we going to use a paper-based system? Are we going to use electronic system? What compliance tool will we use? And I'll show you an example of that in a moment. And then have our policy. So that's our guide to what we're going to do and what the working group is going to do, the monitoring of care bundles, okay? So this was the Excel tool, and this actually had many, many changes between the working group. But we decided we would have the one audit tool, and it's just an Excel spreadsheet that we used, and we'd have the one tool for everything. Okay, so whether it was a peripheral intravascular care bundle, whether it was a sepsis care bundle, whether it was healthcare associated pneumonia care bundle, this is what. The key factors we wanted was the numerator and the denominator. So the denominator was the total number of care bundles that we were reviewing, and the numerator was then the ones that were done correctly. And with the care bundle, no matter how many measures, you should have yeses for all those answers. Okay, so yes, you can have non-applicable, but yes is what you're looking for. Okay, so we used that, and we had a nice formula at the end then that everybody had the same. So after discussion, we identified 2 care bundles to review. We agreed measures to monitor each care bundle, and we started with the following. The peripheral vascular one, so we know 61.5% of patients that come into acute care setting have a peripheral cannula. People are very familiar with handling peripheral cannulas and that. And we also looked at sepsis bundle. Again, we had a national campaign in the last 2 years about improving sepsis management within our hospitals, including the public awareness. So this was when we looked at our measures in each of these. So this is the one for peripheral. We actually found, we weren't too bad. 78, 75% at the beginning. We did a lot of education. And again, the compliance was good. So that was fair enough. That was kind of a well-established care bundle. So that was good. And then we looked at our sepsis. So we did the give 3, take 3. So those were the 6 measures. And again, a lot of education, a bit of a dip there. But overall, we had 100% compliance. So that brought us into our second year, and we thought, right, we're going to expand this now. So we'll have a look at ventilator-associated pneumonia care bundle, and we'd look at the hospital-acquired pneumonia. So at the beginning, you can see our compliance was very poor. Okay, we 28% down to 13% compliance with the VAP care bundle. But we improved when there was a lot of education put in place, and we improved and brought it up. So by the end of 2022, we had improved in our compliance. And the main thing was getting the clinical facilitators involved in those areas to educate the staff about the compliance that we had agreed, the measures we had agreed. And the same with the hospital-acquired pneumonia care bundle. Again, very poor compliance at the beginning, but again, with education, training of staff, and I think the continuous monitoring and reporting back. So we looked for monthly information from this, and then we reported back every quarter to the Quality and the Infection Prevention Control Committee meetings. So the next steps brought us into 2023. And the Care Bundle Working Group, we were well established, and actually we became a committee. And so it gave us kind of more autonomy to do things within the organisation. We were looking at the care bundles, and we realised we didn't actually have a urinary catheter care bundle, and our assessment process for urinary catheter was very poor, okay? So we decided, right, we're going to introduce, so this was our first time actually developing a care bundle from scratch, and then we were going to put it in place and then monitor it afterwards. So we invited the experts from the urology department, and we agreed a timeline. So a lovely timeline. We were very confident, you know, we'll give it this 8-month period, you know, 1 month about dividing all the bits and pieces up and, you know, trialing it, and we'd have it all in place. So review the literature. We looked at the UK guidelines, the Irish guidelines, the CDC guidelines to look at what a urinary catheter care bundle should have in place. We created the care bundle, and we decided we would pilot it into the intensive care unit. It's nice to do it in a small area so that if you do need to make changes, it's more controlled there. We created a training program for the nurses in the intensive care unit, and we said a 4-week trial, we'll review it, and then we'll go back and see. So this was, initially, we had 11 measures. Okay, 11. So trying to get that down to a manageable 5 was difficult, and this was the 5 that we agreed on, okay? So there was a lady speaker this afternoon, Palmer, she spoke about urinary catheter management, and she was saying the key thing is the urinary catheter required? So that was our first measure. Is there documented evidence that the urinary catheter is required? So, you know, take it out if it's not required. Catheter hygiene. Is the patient aware of the catheter hygiene, or the staff? Because if the patient is in intensive care, they need to ensure that there's daily meatal hygiene. Catheter manipulation, continuous connection, and your drainage bag position. Okay, so that was the 5 measures that we had agreed. And this was an example of our surveillance sheet that we used every day. So the nurses in ICU would complete this. We had 8 beds in our intensive care, and we would do it once per shift, in the daytime and at nighttime. And then we had our 5 measures going across. But it wasn't as simple as it looked, because the first thing we realized, we actually didn't have a code for our patients. So some patients come in the morning, but they go out in the afternoon, so you have a second patient in that bed space. So we had to develop a code. The second thing was, where we had no's, we didn't necessarily know why they were a no. So when you go back and you look at this one, actually we had aprons written as part of our measure. But people don't wear aprons if they're doing something with the urinary catheter. So again, that was a diligent nurse writing no. The rest of the nurses had written yes. But so we said we need to review that. We also had no here for this compliance for the drainage bag for the last measure. And again, there's too many questions in that last measure. We didn't know why it was getting a no, okay? So we had to review that. So overall, for this day, you can see that there's 3 care bundles that are non-compliant. So that gave us a compliance of 75% on that particular day, okay? So we were doing this auditing on a monthly basis. So we went back, we looked at the care bundles, we changed the wording, and we made it more simple. And we actually came up with the acronym CHAINS, okay? Is the catheter required? Hygiene of the, educating the patient about hygiene and the staff. Asepsis, hand hygiene, PPE. Is the urinary catheter intact? It's not on the floor, because many times it's hanging off the side of the bed is lower down, it's trailing on the floor. or patients in a wheelchair, or it's moved over, the stand is hitting off the floor. And a 7-day bag change is what we did. So we thought having the acronym CHAINS reminds us of the chain of infection, and it's very easy to actually educate that. And actually that worked very well. So it was a quality improvement that we had put into place. So you can see our compliance went up, and it has improved by keeping it very simple. So this was the original time frame for 2023. Okay, so this is how it went. So actually all over the place. So it's a bit like what Dr. Brett was saying there with her surveillance, that it can be very, very complicated and take much longer than you actually think. So other hiccups along the way, just to tell you what the lessons we learned. This was our VAP care bundle. So as you remember from previous, I said we were doing very well with our compliance. So I kind of took my eye off the ball because I was working on the urinary catheter one. And what happened? Completely dropped. Completely dropped. Now, what happened was here that they brought in a new IT system into the ICU. The care bundle wasn't brought over as we had anticipated that it should be brought over, and hence the compliance went. So it doesn't mean to say that the care wasn't given to the patient the same, but it certainly wasn't documented. Okay, so we had to go back and change that again. So hopefully Q1 of 24, we should see an improvement. I don't have that data yet. And again, with the hospital-acquired pneumonia care bundle, we thought we were doing well. We had got our compliance up to, in the 90s there, which was fairly good. So again, what happened? We had a drop, okay, complete drop. And in this situation, what happened was the respiratory clinical nurse specialist went on maternity leave. So another girl took over her job, didn't understand what care bundles were and what we were monitoring, and was recording the incorrect thing. So actually, we're going to go back and look at that data for the latter half of last year to try and see, was our compliance that poor or not. So the lessons we learned are get the right people involved, okay? So that's very important, okay? So the people that are familiar with that particular, so whether it's an SSI care bundle or a peripheral care bundle or a urinary catheter care bundle, keep your measures short, 3 to 5, and keep very clear language. Audit the process. We found that auditing on a continuous basis improved things, because when I went back every month, I was able to say, your compliance is poor, it needs to improve. And trial it in a controlled area to see is it work. So pilot your audit tool that you've agreed on to see is it workable. Introduce interventions when compliance is low. So it could be just education, it could be an awareness day, it could be getting a rep in from a company to talk about decolonization. You need to bring in interventions and evaluate effectiveness of those interventions as well. So the next steps is what we want to do is we want to expand our urinary catheter. So we have it up and running, it's in our intensive care unit, and we're happy with it now. So we're going to bring it out to the wards. But already we found a problem before we've even started, because we used our S for 7-day bag change, okay? Because we know the urinary catheter bags are changed every 7 days, but they're intensive care patients, they don't wear leg bags, okay? You're back on the ward, now the patient on the ward has a leg bag. The leg bag, when it's connected to an overnight bag, has to be changed daily, the night bag. So it's very confusing. So we're going to have to change this. I might come up with S like stop and empty when 3/4 full. Education, analyze your data further to identify which element of each care bundle is not compliant. That's the one thing I'm not doing. I'm monitoring the compliance with the care bundle overall, but I haven't broken it down to see which measure is not compliant. Again, you need kind of staff to be able to do that. From a drip.org webinar that was on recently, they actually said you don't necessarily need continuous observations. They advise 10 observations at a time, and that should give you a good indication of what your compliance is like. So maybe I need to look at that. Review your outcomes. Again, what is our UTI infection rate? And consider then our next bundle. So remember, perseverance is key. Okay, so that's very important. Keep at it. In all my experience of infection control, it takes about 2 years for something to actually come into place and to be working effectively. So there's our references, and thank you very much for asking me to come and speak today.